PCOS is a very important subject for us. Whenever a patient comes with infertility, we do screen for everyone, and PCOS is so much attention is focused on PCOS not only because of its prevalence, 5 to 10% it is quoted, it's also because of its effect on reproductive, metabolic and cardiovascular consequences. So Dr. Anjali is going to tell us in detail about the newer developments on this important, very important condition.
Thank you, Madam. I want to thank the organizers of Endodibicon, Dr. Ganesh, Dr. Sudeep, for this opportunity. My talk will be on newer developments in PCOS. As Madam rightly pointed out, it's highly prevalent in the population. Because of increased prevalence in obesity, we are seeing more and more young girls presenting with the problem. So what do we already know about this condition? It's common, it's complex, it's highly heterogeneous in the presentation with endocrine, reproductive, metabolic, and I wanted to add psychological disorder in the reproductive age group, which impacts across the lifespan, not only in adolescence, but it goes even post-menopause. The two major underlying key features are insulin resistance and hyperandrogenism, which manifests as either acne or hirsutism. Most of these women have adiposity, mostly in the central adiposity, that is secondary to visceral fat hypertrophy, that makes them predisposed to either IGT or diabetes or metabolic syndrome. And there is no dispute that if you lose weight by any means, reduction in fat mass leads to good clinical outcomes in this subset of population. So my agenda would be what are the new things that have come up in diagnostic criteria, etiology and pathogenesis, therapeutics of PCOS, and what is for future research in this area. Now, diagnosis of PCOS is based on three main features. One is presence of hyperandrogenism. It could be clinical or biochemical. Clinical would be in the presence of acne or hirsutism. And second major is the morphology, which is documented by the ultrasound. So we have gone through over a period of time different sets of criteria, and the most commonly accepted one is the Rotterdam's criteria, which came in 2003, where it says that if you have 2 out of these 3, hyperandrogenism, ovulatory dysfunction or PCO morphology on ultrasound. So if you have 2 out of 3, it is considered to have PCOS. But it is very crucial to exclude the secondary causes for hyperandrogenism, namely Cushing's, late onset CAH, and androgen secreting ovarian and adrenal tumors, hyperprolactinemia, acromegaly. All these are secondary causes, but PCOS should always be a diagnosis of exclusion. So what has come new in this approach is the recently proposed recommendation by the 2023 International Evidence-Based Guideline, which said that probably instead of an ultrasound, we could use AMH values. Why? Because anti-Mullerian hormone is secreted by the granulosa cells of the preantral and the small antral follicles in the ovary. So in PCOS, you know, there are multiple follicles. That's why it gives a, multiple pearl appearance in the ultrasound. So if you have too many preantral follicles, the AMH values are going to be high. So they have proposed that AMH could be used as a surrogate for ultrasound in adults, not in adolescents, because in adolescents we don't do ultrasound. So this is the only change which has been recommended in the newer guidelines, where you could use AMH as a surrogate marker for ultrasound. Again, they adopt 2 out of the 3 features. That is, if you have hyperandrogenism or you have ovulatory dysfunction, and third, either an ultrasound or an AMH value which is elevated. Now, can we use AMH in isolation for the diagnosis of PCOS? AMH could be used for defining the PCO morphology in adults, but not used in adolescents, and it should not be used as a single test for diagnosis of PCOS. In patients who already have clinical features of irregular cycles and hyperandrogenism, we do not need an AMH level because you have clear-cut clinical features of PCOS. And we should be aware that AMH can have inherent variations. It is usually peaks between the ages of 20 to 25 years, and it is lower in those who are obese. Uh, with respect to medication, if a woman is on OCPs or if she is on GnRH agonist therapy for fertility treatment, AMH values can be falsely suppressed. So we should be aware of that as well. With respect to various phases of menstrual cycle, we do not see much variation in AMH levels, but theoretically AMH levels can go high up during the early follicular phase. So mild variations are seen to the tune of 10 to 11%, which is not significant. Now coming to adolescents with PCOS, it's very difficult to diagnose PCOS in the first 1 year of menarche because cycles are anovulatory in these young girls. Post 1 year menarche or less than 3 years post menarche, if a young girl has irregular menstrual cycles, say more than 3 months of amenorrhea or hirsutism or acne, which is a clinical sign of hyperandrogenism, so you should have both. You should have both irregular cycles or a primary amenorrhea 3 years post menarche and hyperandrogenism. Then we can consider this young girl to be at risk for polycystic ovarian syndrome. Remember, we should never use pelvic ultrasound in adolescents to diagnose PCOS. Ultrasound is often offered only after 8 years post menarche when they have achieved reproductive maturity. So never order for ultrasound in young adolescents to make a diagnosis of PCOS. So this slide was to highlight that fact. Now, what is new in ultrasound criteria? Now, there are some new terminologies which have been recommended. One is to calculate the follicle number per ovary. Second is follicle number per cross section and to check the ovarian volume in 3 dimensions. So, if one of the 2 ovaries shows more than 20 follicles or if it shows more than 10 ml volume or if it shows more than 10 follicles per section in one of the ovaries, it can be considered as a threshold for defining polycystic ovarian morphology. Between abdominal and transvaginal is always considered more accurate for the diagnosis of PCOS. Again, I would highlight that this should not be offered to adolescents. So the other recommendations from the newer guidelines in 2023 is all women with PCOS should be assessed for cardiovascular disease risk factor. PCOS is considered as a high risk group for future metabolic syndrome and future cardiovascular disease. So all these women should have their blood pressure monitored. Lipid profile should be offered to all women irrespective of age and BMI. They can be lean but still they are at risk for future metabolic syndrome. Glycemic status should also be assessed at diagnosis for all adults and adolescents with PCOS. We can offer either a glucose tolerance test with 75 gram glucose or ask them to do a fasting blood sugar and HbA1c, which could be reassessed every 1 to 3 years depending on their inherent risk factors. They have a very strong family history of diabetes or they are obese, every 1 year. Women with PCOS should be assessed for symptoms of obstructive sleep apnea. And what is new in this recommendation is they have said that the risk in the first degree relatives, especially the fathers and the brothers of these girls or women, are at high risk for future metabolic syndrome as well. The evidence has not shown much correlation in the sisters though. Psychological assessment is very important because they are prone for depression, they are prone for mood disorders, eating disorders, and hence psychological assessment is recommended. Now coming to etiology and pathogenesis, what is known to us is there is a high level of LH in these patients, and this high levels of LH is because of high activity of the GnRH pulses. The pulse generator in the hypothalamus gets activated and there is higher LH pulse. The high LH goes and stimulates the theca cells and the theca cells produce more androgens within the ovary. These androgens would lead to a follicular arrest. So the follicles stop growing at this phase, they don't mature to a graphene follicle stage and ovulation gets affected. So this is what we know, and what leads to this high GnRH pulse generator activity. So the proposed mechanisms or etiology are: 1, it could be a genetic predisposition to PCOS, or it could be environmental toxins. We are talking about a lot of plasticizers and endocrine disruptors in the environment. Alteration in gut biome, I will come to that in future slides. This is what is being looked at in current research. And of course, this is the most important thing, diet and lifestyle. So this all leads to obesity, hyperandrogenism and hormonal imbalance. Coming to genetic predisposition to PCOS, 10 to 15% of women with PCOS may have genetic predisposition, and these are due to genetic mutations or single nucleotide polymorphisms in enzymes related to ovarian and adrenal steroid synthesis, insulin secretion and action, IRS1, insulin receptor, effects of steroid hormones, gonadotropin action and regulation, and some others. So this genetic cause for PCOS is, however, lesser prevalent. Now what is being more understood is the fat tissue. Adipose tissue is not a simple inactive thing, but adipose tissue is a very active endocrine organ. In women with PCOS, adipocyte dysfunction is well documented in many studies. And what does a normal adipose tissue do? An lipid metabolism involves genesis and lipolysis, and there is a balance between the two, and hence the glucose metabolism goes at a normal pace. But whenever there is excess lipolysis or excess free fatty acids, this gets disturbed. Adipose tissue also is a source for chemicals called as adipokines. Some of these adipokines like adiponectin, vistatin, omentin and IL-6, they promote insulin sensitivity, whereas resistin, leptin, they promote insulin resistance. So the lipid tissue is a very active source of adipokines, some of which increase insulin resistance, some of which suppress insulin resistance. Now this picture is to highlight the difference between smaller adipocytes and larger adipocytes. We have two types of fat cells. The small adipocytes are associated with good metabolic health. They release omentin, adiponectin, IL-6, which are more promoting insulin sensitivity. And the larger adipocytes, they are sources for free fatty acids, leptin and resistin, which increase the insulin resistance. So the adipokines studied in PCOS have shown lower adiponectin levels and higher resistin levels, which promotes insulin resistance. So that is a basis for higher insulin resistance in girls with PCOS. So essentially to highlight the fact that the adipose tissue, whether a woman is lean or obese, both these women, they document adipocyte dysfunction. Now what is this brown adipose tissue? We have two types of adipose tissue, the white, the brown and the beige. The white adipose tissue is further divided into visceral and the subcutaneous. The visceral is what is located around the organs and increase insulin resistance. The brown adipose tissue is usually seen in the neonates, and in adults it is seen in the paraspinal region and the suprascapular area. The brown adipose tissue is highly thermogenic, more than 300-fold heat production is seen. It acts as a sink where all the triglycerides and the glucose from the blood seeps in. So it leads to increased fatty acid oxidation, reduces the plasma triglycerides because it mops up the triglycerides from the blood, reduces atherosclerosis and inflammation. The adipokines which come from the brown adipose tissue is known as the brown adipokines. So I'll come to that. The purpose of showing that slide was in therapy of PCOS. So if you look at the adipocyte dysfunction in PCOS, we can classify into these subcategories. That is, the adipose tissue increases in amount, adipose tissue hyperplasia, and there is impaired adipogenesis. Especially you see larger adipose tissues. This leads to impaired insulin signaling and glucose transport, dysregulated lipolysis, adipokine dysregulation, which I told you now, and also mitochondrial dysfunction and ER and oxidative stress is found to be elevated in these patients. Now this was the model to show, picture to show what the lipocyte hypertrophy can show. So in PCOS women, the normal adipose tissue, when there is weight gain or caloric excess, the adipocytes become larger in size, they become hypertrophied, and when they become hypertrophied, the blood supply to the interior of the adipose tissue comes down, leading to tissue hypoxia, and that hypoperfusion leads to release of all these chemical, activated NF-kB pathway, increased macrophages, and it stimulates inflammation. So this slide was shown to mainly show that PCOS, especially when the women are obese or overweight or have higher amount of adipose tissue, it leads to a state of chronic inflammation. Inflammation essentially because of lipid hypertrophy, and these inflammation can lead to more and more of insulin resistance and leads to metabolic syndrome. When it comes to insulin signaling and glucose transport, the salient feature that is seen in women with PCOS is you need glucose, the GLUT4, the glucose transporter 4, for the glucose to enter. And what they have found is the insulin stimulated glucose uptake is reduced because the GLUT4 production itself is reduced in women with PCOS. So what is epigenetic dysregulation? It starts very much in the prenatal life itself. A mother who already has a higher AMH or the fetus is exposed, the prenatal androgen exposure to the babies itself can predispose to PCOS in later life. This is essentially due to DNA methylation which can happen in these fetuses, and that leads to PCOS in later life. So this epigenetic regulation of adipose tissue occurs via what is known as microRNAs. These are single stranded RNAs which are non-coding, and they are involved in the post-transcriptional regulation of gene expression and affects both glucose and lipid metabolism. So a mother who has PCOS may actually give birth to a baby. That baby can be predisposed to PCOS in later life, and this is the concept which has been explained by epigenetic dysregulation. Talking about role of environmental toxins in causation of PCOS, now there is a lot of interest in looking at endocrine disrupting chemicals. Most of the studies in literature have looked at bisphenol A and others at parabens and triclosan. This usually comes through contaminated food. It can come through polluted air, but most commonly through pharmaceutical and cosmetic products. Bisphenol A comes essentially from lot of cosmetic products, and many of these have shown presence of bisphenol A. So newer recommendation has been to go to the other forms of bisphenol, bisphenol F and D, which are less toxic. And the negative effects of these chemicals on ovarian function has been well documented in both humans and murine models. It can reduce the antral follicle count within the ovaries. It can cause lot of other factors. It can disrupt the oogenesis and early meiosis stage. It can cause upregulation of the GnRH pulse activity, so the LH values can go up. Most importantly, they reduce the antral follicle count, and AMH values can eventually fall in these women. So what are the targeted therapeutic strategies for PCOS? There is no dispute again that the first and the most important intervention is weight loss. Lifestyle intervention, so you tell them on diet and exercise. There is no, and the second commonest drug that we use is a combined OC pills. Combined OC pills are used mainly for a woman who presents with features of hyperandrogenism and menstrual dysfunction. So these three categories we use oral contraceptive pills. Anti-androgens are usually added, one for androgenic alopecia or with higher grade of hirsutism or higher grade of hyperandrogenism, either in isolation or in combination with estrogen and progesterone. Insulin sensitizers, the most commonly used is metformin, which we use in women who have glucose dysregulation. Either they have impaired fasting or metabolic syndrome, we use metformin. Now, do we have role for other drugs in PCOS? So the other drugs which are used are thiazolidinediones. We don't use it commonly in clinical practice, but thiazolidinediones are very good ovulogens. It has been documented that it is much better than metformin in inducing ovulation, but it can cause weight gain. So that is why it has lost its popularity in regular practice. Inositol. Inositol, we can use myoinositol or D-chiroinositol. There are two isomers used in the treatment of PCOS. The D-chiroinositol restores insulin sensitivity by reducing the androgens, whereas myoinositol predominantly gets concentrated in the ovary and it aids the FSH signaling pathway. That way the ovulation, there is no arrest of the antral follicle development, and it results in regular ovulation. The newer drugs that have come into the market are, the research is still on, the role of GLP-1 receptor agonists. Now, the GLP-1 receptor agonists or the dual GLP-1 and GIP, they have been used in diabetes, mainly promoting weight loss. And as I have already said, in women with PCOS, any amount of weight loss, even 5% of body weight loss, can lead to ovulation. And these drugs are being looked at in women with PCOS with an intention to lose weight, and weight loss itself improves reproductive outcomes in these women. So how does GLP-1 agonist work? It reduces appetite in these patients, it increases satiety, it inhibits glucagon release, and essentially it causes the glucose releases. Sorry, can I take extra 10 minutes? Yeah. So the drugs that have been studied in this category are mainly liraglutide and liraglutide. We have more studies are required. They have seen that the weight loss is to the tune of 5 to 7%, but weight gain can again happen after stopping the drug. So essentially the woman has to be told that if GLP-1 receptor agonists are being used for weight loss, they have to continue their lifestyle changes that they have been advised to follow. And essentially these semaglutide, which is in the market, and even tirzepatide, which is dual GLP-1 and GIP agonist, again primarily by virtue of weight loss, has been found to be beneficial in women with PCOS. But to use it regularly in clinical practice, we need more and more future researches on. The other class of drugs that can be used is DPP-4 inhibitors. Again, it increases the level of incretin hormones, and it regulates the blood glucose by stimulating the pancreatic insulin secretion, suppresses glucagon, but it is considered generally a weight neutral drug. But it has been found to reduce visceral fat, and the drugs that have been studied in PCOS so far is sitagliptin, linagliptin and alogliptin. But these drugs, when used in combination with metformin, have been found to be quite effective in women with PCOS, but we need more data. The third group which is being studied is SGLT2 inhibitors. This group of drugs, they inhibit glucose and sodium reabsorption in the proximal renal tubules, and it causes weight loss to the tune of about 5%. The initial weight loss may be very moderate, and if the patient adopts lifestyle, probably the weight loss can be a little higher. The drug that has been used here is empagliflozin. We have studies which have looked at very short duration of usage, so we cannot apply it in a clinical practice, but it has led to weight loss, reduction in waist hip ratio and other anthropometric parameters when compared to metformin. So SGLT2 group inhibitors again can be offered to women with PCOS who have underlying diabetes. Now I wanted to present this slide on altered gut microbiome. Now we find that there are a lot of microbes in the intestine, and women with PCOS have been found to have abnormal bacteria. That means the good bacterial population is less and the bad bacterial population is more. We see more amount of enterobacteria. So studies have reported a specific increase in harmful bacteria like E. coli and Shigella, and reduction in beneficial bacteria like the lactobacilli and the bifidobacteria in women with PCOS. So because of these bad bacteria and enterobacteria, even the effect of this is there is if you see that here there are these gut with, especially when the bad bacteria populates the intestine, the inflammatory pathways, that is the MAP kinase and the nuclear factor kappa B signaling pathway gets stimulated, leading to a lot of inflammatory factor, leading to higher grade of inflammation in the gut, and that the mucosal integrity gets broken because of the higher grade of inflammation. And this higher inflammatory response in the gut can impair the GLUT4 expression, the insulin signaling pathway, leading to more and more of insulin resistance. So there is something called as an inflammatory pathology related to the gut microbiome alteration in women with PCOS. So how do we treat this kind of they have suggested we could offer them probiotic, prebiotics, and there's something called as fecal microbiota transplantation, which is a new therapeutic option of PCOS, where microorganisms from feces of healthy donors can be transplanted to the intestinal tract, and this has been found to alleviate hyperandrogenism and regulate menstrual cycles. So other novel therapies are, I have told you that the GnRH pulse generator is hyperactive in women with PCOS, and this is due to peptides like kisspeptin and neurokinin 3. So if we block the kisspeptin or the neurokinin 3, the GnRH pulse activity can be reduced, LH activity can be reduced, and these are the areas where future research is on, whether we can actually start blocking the primary CNS hyperactivity, that is the primary GnRH pulse generator itself. We can target the inflammatory pathways. As I said, there is a constant state of chronic inflammation in women with PCOS. Probably there could be a role for NFKB, the nuclear factor kappa B inhibitors, and some role for miRNA therapy. Then talking about brown adipose tissue is a good, and if you increase the amount of brown adipose tissue in someone, the amount of insulin resistance can be mitigated. That is, how can we convert a white adipose tissue to brown adipose tissue? It is very difficult, but theoretically it is possible by prolonged cold exposure, high protein diet, capsaicinoids in diet. Thyroxine can activate brown adipose tissue, beta adrenergic agents, ginseng extract, all these are proposed to increase the amount of brown adipose tissue. Cold exposure may be a novel strategy, or can we transplant brown adipose tissue? Now these are areas people are looking at in mitigating insulin resistance and mitigating chronic inflammation in these individuals. So essentially PCOS becomes a good window of opportunity. As we say, gestational diabetes is a good window of opportunity to prevent future diabetes, future metabolic syndrome. You pick up these girls young and start counseling from a young age. Not only them, their mothers. Mostly, as I said, epigenetics. The mothers may also have PCOS, for all we know. So I think it's an intergenerational transmission of insulin resistance, which we can probably intervene by counseling them adequately, and mainly, most importantly, lifestyle modification and weight loss is the most I think important intervention we can offer in these women. So with that I'll conclude, and if there are any
we see it is very difficult for them to lose the weight. That is a very obese patient, they find it very difficult. Probably counseling and motivation, all that is required along with the drugs, medicines.
So that's why these newer drugs which are there for anti-obesity. So women who already have diabetes and obesity can be offered GLP-1 analogs, which reduces not only the metabolic syndrome but also reduces the cardiovascular risk. But we need more and more studies in women with PCOS before we offer them. But we can give them this drug, especially if women with PCOS have underlying diabetes, and if they are trying for a fertility, they can lose weight with GLP-1 analogs, give a washout period, and then go for a fertility treatment. So this aids weight loss, but nothing like diet and exercise.
Yeah, we have been using metformin and myoinositol and decaroinositol, but other drugs
Metformin as a weight loss agent may not be very good, because the amount of weight loss that we achieve with metformin can happen only with very high dosages of metformin, more than 1.5 gram or more than 2 gram. But the weight loss is very modest in most patients.
Thank you very much. It's open for discussion, the forum.